Hello, good morning, afternoon, or evening. I am Steve from Integrated Health Sciences, and I would like to welcome to the webcast today, Dr. John Lawrence. Thank you so much for coming on, Doc. How you doing today?
I'm doing very well, Steve, and thank you for having me on. It's really a pleasure to be able to join you.
It is a pleasure and an honor to have you in the house. I enjoy our conversations no matter where they are, no matter when they are. And it's really nice to get to have this conversation between you and I in front of people so that hopefully we can help them out. So I'm going to start with my story when it comes to Doc. And it starts like a lot of gym relationships start. The casual smile and the wave that usually goes on for 6 to 8 months maybe before you finally get the courage to talk to the other person. I would see Doc working out kind of like a beast for a long time and just always would be like, oh, that guy looks like he's got his together. And then I read through your shirt, which was a Doctors Without Borders shirt. And I had just come back from, I think, maybe my second or third medical mission in Ecuador. And it was something I just wanted to talk to you about. I asked you, hey, any affiliation with them? You were kind enough to humbly share that you were the former president, or maybe at that time you were even the president, but in a super cool way. And then we connected on that and then just always kind of enjoyed each other's company, developed into a little bit of a relationship as far as that was concerned. And it was always nice to just kind of have you to pick your brain about medical mission stuff or medical stuff or whatever it was. And that's kind of how you came into my life up until the day we're kind of going to talk about. But tell us your story, Doc, and spare no detail.
Yeah, well, thanks, Steve, for the bit of the introduction. And yeah, just I think for a bit of an overview in that regard, I am, kind of going way back, native of the Midwest. Didn't anticipate that medicine was something that I was going to pursue as a career, and wound up getting steered that direction by a little bit of serendipity, to be honest with you. So it wasn't one of those things that was what I thought I wanted to do my whole life. Then was in medical school, fortunate enough to get support from the U.S. government and the U.S. Public Health Service in particular. So wound up to having a payback period that I was obliged to do. And so was in primary care, family practice, or general practice for 5 years and worked out on the Navajo Indian Reservation. Then realized that surgery was actually what I wanted to do professionally. So went back to train in general surgery and then specifically pediatric surgery. And backing up again just a little bit, when I was in medical school, I got interest and then, progressive exposure to international health or global health, and kind of that became kind of a sideline or a track that I wanted to be involved in. Anyway, finished up my training in surgery, was working as an academic pediatric surgeon, and that was the time that I could then start doing little shorter overseas surgical trips, and got kind of attached to that. And much as you've done work similar to that yourself, so understand that. But in the back of my mind, had always had this desire to make it a more prominent part of my work, and was finally, actually well into my 50s, able to start working with the group Doctors Without Borders, or Médecins Sans Frontières, or MSF as it's known. And so did several assignments with them, working internationally over about a decade, got elected onto their board of directors, and then, as you alluded to, served as the president of the board of directors for 3 years. And just actually finished my last year on the board now about 6 weeks ago, actually. So have kind of finished that all up. I term limited out at that point. So I've had this mix of interest in, academic medicine, in this mixture of surgery and pediatrics. And so teaching has been part of what I've been doing for much of my career, mixed in with this global health side interest that started becoming more consuming, and still, still today is something I'm very passionate about.
That's awesome, Doc. Can you give us two things? One is just tell us one story, kind of like that one moment that it was that like, oh, this is exactly what I'm supposed to be doing right now, or that moment you're most proud of, or maybe even that moment that moved you the most, perhaps in a negative way, where it was really emotional for you. Can you give us one moment, and then take just a moment and just put on your global health hat and just speak a few words of what's going on currently, because we are in the middle of a pandemic. It would be weird not to talk about it just a little bit. So share with us both of those if you don't mind.
Yeah, sure. So to talk about, maybe what I would say has been the most satisfying and maybe I could say gratifying part of my medical career, really, in the last, I guess it'd be about 3 years ago, got involved in a pediatric surgical project in Monrovia, Liberia, so in West Africa, and quite unique in that it was, a bit more specialized than most of what Doctors Without Borders had been doing prior to that, but also, and I think in a very interesting and quite pertinent way, very much driven from a community-based or a ground-based interest and desire, meaning that people working in that project at an existing pediatric hospital had said, we feel like we're doing pretty well with general pediatrics, but we're not doing as well when we have to refer patients with surgical conditions. And it was both surgical expertise and anesthesia, safe anesthesia care that were concerns there. So this is an ongoing project, and one that I'm actually hoping I'll be able to get back to here, and depending on travel restrictions and all of that, but hopefully get back to in the next 4 to 8 months to kind of continue those efforts. But a very I think I would say rewarding in that this has been a project that's designed to empower the people of Liberia. So we're trying to train anesthetists and surgical personnel in kind of advance the level of expertise they have in more specific areas within pediatric surgery and pediatric anesthesia, with the idea being that we'll actually be able to turn this over to Liberians, and that's kind of a 5-year timeline. But if you said, what's been most gratifying or satisfying that I've done, that would be it for sure. Not that kind of the day-to-day care of taking care of children or patients otherwise isn't, but that kind of stands out. And then flipping that into what are the impacts? And I think I would, be talking now internationally with COVID-19 and how is that affecting things. And so, the answer is it obviously depends to some degree on where you are and what where you are in the world in particular, and what's available in country for resources. But in no particular order, obviously, restrictions on travel and supplies and equipment has really constrained the ability to respond appropriately in a lot of parts of the world. So we obviously have had the supply chain issues here in the U.S. that have been problematic at times in the past, and to some degree, from what I'm reading, still continue to be problematic. But we also have a capability here of gearing up, manufacturing industries and so forth that can reroute what they're doing in country, whereas in a lot of places that's more of a challenge. Talking about many of the places in lower resourced areas, frankly the prospect of salvaging patients who get critically ill is really very difficult. So intensive care and ventilators, not something that they have access to. So there the emphasis has to be on more on the ground preventative measures, and it's exactly as hand washing, wearing masks, so those are very important. And in that regard, as tragic as it may sound, but some of the epidemics that have gone through, not only in Asia but also in Africa, so Ebola coming to mind, have been very good public health training for the countries there. And I was more than, not that it was affected by Ebola, but more than a little bit intrigued to read when the European Union opened up the list of countries that that they would accept visitors from currently, Rwanda was on that list and the United States wasn't. So it speaks to, kind of wealth and might isn't the sole determinant, obviously, of how well one can respond. So some of the areas of social or community cohesiveness that have been viewed as a problem here in the US are actually better implemented or executed in other parts of the world that don't have the degree of technology or access to medications, that kind of thing, is readily. So that's clearly a very big part of it. And I think the last comment I would just make in that regard is that what this pandemic, I think, has shown is the importance of health equity, or how health inequity is magnified at times like this. So that's been very true here in the United States, where it's populations with lack of access to health care with multiple underlying diagnoses, which tends to unfortunately, correspond with, various determinants of social stature. How important those are, how important those determinants are for affecting who's going to get disease and then what their outcomes may be. And we see that same thing elsewhere. So when we talk about, well, when this vaccine's available, how is that going to get distributed? And again, there's a little bit of the haves have and the have-nots. It kind of that imbalance can be accentuated unless there's really a proactive effort to even that playing field as much as we can.
Yeah, that light being shined while our nation's looking at itself in the mirror isn't always as pretty as you want it to be. So yeah, I understand what you're saying. So take us through the night. So it was January 29th. I just happened to remember that off the top of my head.
Yeah.
January 29th was a night where I'll just tell to start off, like, I was just doing some Instagram work and you were doing something different. Tell us how that night went for you.
Yeah. So that night, and for people looking in who may be elsewhere, I was living in New York City at the time, and so working out at the gym facility that is your kind of home away from home, and did what I would call kind of my standard routine at the time. So had gone out along the Hudson River and probably done about a 4 or 5 mile run. And it was kind of a chilly night, but in the way that, again, anybody who are regular fitness, I don't know, fanatic may be an exaggeration, but who maintain fitness in their lives, realize some days you feel like it's just a struggle from the get-go and you try to work through it, and other days you're just feeling great. And this is one of those days I was feeling, wow, it just feels good. All the prior toil and sweat is paying off. And so had this run and then came back into the gym and was doing, again, what I would call was my then sort of follow-up routine. So really a mix, and without realizing that, again, there's a lot of people with far more expertise on what's a good regimen or not a good regimen in that regard than I might have. But what I would say was my routine. So a mix of some weights, some, high intensity jumping rope, and then kind of a more, some stretches also thrown in there. So really a mixed bag of activities following that, and had probably been at it for about an hour and a half. So, in the way that it's not all about duration, but, a fairly longer workout compared to some that I may have had for sure in the past. And was, basically at the very tail end of it. So was just doing some sit-ups and all of a sudden had this I think the best way I would describe it at the onset was kind of an odd sensation, being just a little bit lightheaded and really not anything more. And at the outset, I didn't really think much of it, to be honest with you. It's something that I would say I would experience, not to the magnitude that it accelerated to, but it experienced in the past, and would kind of write off to, I pushed a little too hard here. Frankly, the aging process, you realize you have to kind of slow down a little bit as time and the years go by, but nothing that really struck me as extraordinary. But at the outset, it was just, I just need to back off a little bit. And but it got to a point where I just felt this, it's very nondescript, but kind of odd feeling. And then almost had this, and it's a hard to articulate, but I would say a little bit of vague feeling of kind of this hollowness or almost cold feeling in my chest, but certainly not classic pain. So I just stopped what I was doing and thought, well, whatever this is, maybe it's a little bit of my heartburn, maybe it's, as I say, just going too far too fast. And thought if I just rest, whatever this is going to pass, because it didn't concern me at the outset. And I kind of sat and waited for about 30 seconds, and it just kept feeling a little bit strange. And so I got up from where I was and walked the kind of 10 yards, or, if that's probably an accurate distance, but to where your area, where the physical therapists kind of have their their clientele and services delivered in the same gym, and walked in there having seen you there previously in the workout, and knew, well, if whatever this is hasn't passed, at least I know somebody who I can kind of bounce off of. What should I do? What do you think's going on? So I walked back into that area, and again thinking, well, if I feel good, I'll just kind of walk back out again and continue to finish up the workout and call it a night. And got back there and still wasn't feeling well, in just that kind of same vague way, but more lightheaded. Something's not right than any avert. I'm really in pain, at least at that point in time, and so I got to where you were, and I just sat down, and that kind of had this moment, this really is something more significant. I need to, to kind of call a friend, so they say, or recruit some assistance. And so my recollection is you were talking on the phone, and I thought, oh, I hate to bother him, interrupt him. It may be one of his clients, it may be work related. And, but just to kind of recall, saying to you, Steve, I'm not sure what it is, but something's not right. And I think you need to call some help for me. And yeah, I'll let you take over from there. But from that point for me, a lot of my memory was kind of patchy, to be honest with you. And we can circle back through that at a later moment.
So I was on the phone with former President Obama. And I was just like, all right, Barry, sorry, I got to run. I know you want to tell me about what you have for lunch, but this seems really important. So I hung up the phone and came over to you, and you were just it was kind of like a, what's up, doc? Because I know you would never, there was not a doubt in my mind the moment that you interjected, and I don't say that in a negative way, but something was up, that wouldn't have naturally happened. So kind of the antenna already goes up, unfortunately. And then when I looked over towards you, you kind of were just I'm just having trouble right now. And that was, you said that you were lightheaded and that you were having a little bit of trouble breathing, but really it seemed it was more just kind of disorientation, and more like what you were saying is a hard to describe lightheadedness and a hard to describe sensation through the chest. And the first thing was hey, should we check your pulse? It just seemed like the normal, natural thing to do. And I've checked a ton of people's pulses in similar situations. In a boxing gym, sometimes people just pass out. They've never done a class before. They come in and it just happens. And they always have, because they've been working out, thudding pulses. And yours was the complete opposite. It was hard to find, but when I found it, I knew I was on it, and I knew that it wasn't pumping. I would say, from someone who's never been in that scenario, I would say you're probably hitting at about 20 to 25% of how much I felt like I should be able to feel of that pulse hitting out at me. And that was, I think, quickly, if we hadn't already, that was very quickly then the like call 911. It was call 911, and it was unfortunately like that's when you started to articulate the chest, which thanks for kind of articulating that. I don't know if we would have gotten there as quickly as we did, but it is nice when you have someone who's a doctor to kind of guide you in these uncomfortable situations. But we had an AED that was at the gym. Yay, Gotham. Went and got it. It was helpful because Chris was there, who was former military. Claire was there, who was just being super helpful. And Stan, I don't know, he's Russian, and I don't know if that just makes him better in these situations, but he kicked ass as well. So the real main thing was get help as quickly as possible, stay on the line with 911, and then it was monitor your pulse. The only thing that we tried to do was maybe play around with some positional stuff with like getting your legs up, see if any more blood to your head helped. It didn't seem to help. Maybe it hurt. I don't know. I'll let you answer that if you think it's valuable. But then the only thing that we did was we put the AED on you, which for anyone who's in that scenario, don't be afraid of the AED. Just go get it. If you've never done it, it's so self-explanatory. It tells you exactly what to do. The pads are well labeled. The voice cues are well defined. There's no real room for error. I really would say probably a 9-year-old could probably handle doing an AED. And we strapped you to the AED. And this was where it's kind of weird. And I do want you to answer this before we kind of get into this, but it told us to start doing CPR. So it did not shock you, but it told us to start doing CPR. Should we have done CPR? Like you were talking to me. So
yeah, and I would say, generally speaking, no. If somebody is able to communicate, that means that they've got a pulse, and and again, that they're able to breathe. So, so yeah, I would say that without trying to countermand the AED, because it's much as you were saying, it's really designed to make things as simple as possible. And so in that regard, it generally should be, to follow the instructions. So I'm not sure I could explain why it would have said that. And just maybe to reiterate one other thing, that you said about, don't be afraid to use it. And I think the real key, especially for people in their workplace, is to know where it is. It's kind of like the fire extinguisher in your home. You say, yeah, great. If there's ever a fire, I'll get the fire extinguisher out. And, but if you don't know where it is, you won't be able to do that. Or if you have to look in 5 different places. So sounds like a basic thing, but for, again, people in a gym, or if you worked in a mall or in an airport, kind of, whatever it may be, know where the device or devices are kept, because the sooner you can get it out of the cabinet, the box, or wherever it's stored and hooked up, the better it's going to be.
Yeah, that's a great point. It isn't not being afraid is really important in using it. But yeah, probably the number one mistake that happens the most isn't either of those two. It's just not knowing where it is, or I hate to say it, not having one. So encourage your office managers and anyone else, get an AED. They're not that expensive. Get a refurbished one. Hey, you were fine. That one was refurbished. It worked. So whatever. And something that we will do is hopefully we reached out to FDNY. Hopefully we're going to be able to get an EMT in on this conversation, might do a part 2. So maybe they'll have a different answer for us. So that's really helpful. So AED tells us what it tells us. Operator tells us aspirin, which was really helpful. And something that frankly, I should have caught and done straight away, but teamwork. And that was kind of it. The rest of it was, I have to mention, it was the sweetest thing, and I will try not to get emotional, but your concern for your wife, even in your most concerning moment, was truly beautiful. And then it was really letting the EMTs who came in first, let them do their job. And then the paramedics who came in, who more or less were like, once we have you here and we have the ambulance, there are very few things that we can't do with our skill set and with that ambulance that can't be done in an ER. And that was really, really comforting. I have to say, like, way to go, FDNY, way to be rock stars. Webb, Trinidad, if you happen to be listening, you are the greatest. So now we kind of run through and I'll kind of relay the conversation. But I think in those moments, the real question is, once it's been established, yes, this person is having a heart attack, do you give them nitrous oxide? It was discussed between you and the paramedics that nitrous oxide was not the best course of action in that moment. Do you have any idea why? You seem to have an opinion on it in the moment. Do you have any idea why that was possibly the case?
No, and I'm just to double back with you on that. Do you mean oxygen or nitrous oxide?
They said nitrous. They said that they didn't want to give you nitrous because they didn't want to send you into full arrest.
Yeah. Okay.
You seemed, whether you were just playing along, just being an awesome doctor and just like, yes, I concur. Do you concur? I concur. But you seemed on board with that at that moment in time. Once again, maybe a question for the paramedics.
Yeah. No, and I just and again, to circle back on a couple of things that you said, because, first off, that, I would like to kind of reiterate sort of a shout out to the Fire Department of New York broadly. And it was, the first responders were Engine Company 24, Ladder 5, Battalion 2. So that's kind of the neighborhood fire department. And, we lose sight of this, but for a lot of people in New York, they're, in a 5-story walk up, and it's, that you to get somebody into the through the front door of the apartment or into the apartment itself, they're really critical for making that all happen, to be able to get on the scene and assess what's going on. So shouldn't lose sight of the, the great job that they do every day, and, talk about unsung heroes, but I feel very strongly that, so much of what they do is not fully appreciated. And then, to the EMS Station 7, which is, 23rd Street and 10th Avenue. And it was Trinidad and Webb who were the paramedics that came specifically. But again, everybody there who, and we can touch on this a little bit later too, about how fortunate I was in so many ways. But the fact that this was just pre-COVID, they were there in a matter of minutes. And, the demands that those services have had collectively over the time when COVID-19 was peaking in New York can't be, underestimated. And so again, very professional, lots of, skill and expertise that they have. And so, want to make sure that they get an appropriate acknowledgement as well in those early phases. And for kind of, I think you highlighted, I think largely what you want to then be doing is, for lack of a better phrase, but get out of the way, so that the people who are professionals can do what they want to do.
Yeah, and that's exactly what they were so good, and we can sing their praises for another hour. But I will say it was just so nice to see people be so good at their job in such a stressful moment. Yeah. And it was amazing. And so then ambulance over to the hospital. And that was like clockwork, partially again, because they were so on it. They knew exactly what they were dealing with. So they knew what to give the ER heads up on. And it was a total just touch and go at the ER. You guys, I think, reminisced about doctor talk residency stuff. It was cute. And then you were straight up to the cath lab and in surgery quicker than it probably takes to get French fries at Shake Shack, frankly. So from that, then kind of the story goes off. I mean, I got to connect with your amazing wife, Leola. She's amazing. We could, again, talk about that for an hour as well. But that was really where kind of my story ends, because once you got into surgery, there was nothing that happened on my end until you came out of surgery and I saw your smiling face. I gave you a big hug and I went on my way to ride a bike and cry just a little bit. No big deal. Like, that's just how it goes in these situations. And that was where my kind of like experience with what went on January 29th ended. But that's kind of like where yours now picks up as far as reflection. And also talk us through kind of what happened from when you left the ER to go into the cath lab till we saw your smiling face in recovery.
Yeah, well, it brings up a whole nother aspect of this from my perspective, because I sort of touched on coming into the area in the gym where you were physically located, but it wasn't long after that presumably just because my heart wasn't pumping or functioning effectively enough to really perfuse my brain adequately, even though I was conscious appearing, I was really very much in this in and out phase in terms of what I can remember. So I remember, a bunch of the fire department members in that room and kind of around me. But there were big gaps in what was probably an hour and a half or so of time that I had no recollection of. And I had these little snippets. I remember going out the door of the gym because I was in sweaty workout clothes, and to get into the ambulance was, at 15 seconds outside in the, whatever it was that night, 25 degrees or whatever it may have been. So I remember thinking it was really cold, but then was just kind of out again. And then I remember actually part of the ride over, then really having some very intense chest pain, but then that passing. I remember you talking and thinking, oh my gosh, Steve is in the ambulance with me. And let me just use this, by the way, as a chance to give a shout out to you directly, because you were phenomenal. And, in supporting Leola, my wife, who, was also great, but took a little while to sort of get her bearings, because obviously very disorienting, but you were fabulous talking to her. But just, it says a ton about who you are, the fact that you were actually in the ambulance that whole time and kind of changed your plans for the night. Anyway, getting back to the hospital itself, again, I remember going into the emergency room, signing a consent form for, and frankly, not really knowing for what, and then going up to the cath lab. And then that was at the point they actually wound up, giving me medication before doing the cardiac catheterization and then the actual stent placement. So the procedure, as it were, you're referring it to surgery, but it was all, again, kind of remarkable. It was a tiny little needle stick in my wrist that this is all done through. Yeah. And the last thing I would just kind of say in this part of things too was that, and you highlighted that the paramedic team coordinated what hospital to take me to, so that the cath lab was physically and the personnel waiting for me when I arrived. And so, again, we can get into how important timing is from onset of symptoms till you relieve a blockage related to cardiac events like this. But it's easy to grumble about the city and what it doesn't do well and various agencies and bureaus within it. But this has really been well thought out, well coordinated. And, again, in my case, I think made a huge difference.
Yeah. And the ambulance ride, it was beautiful. So, and again, this is like just the moment to like share the humanity of it all. Like in the gym, it was obviously like, just text Leola, like just tell her I love her. And that's exactly kind of what it should be like. Once you knew that she was taken care of, your focus switched to your kids, which was just like, so that was the ambulance conversation that you don't remember. Mm-hmm. It's just worth kind of letting you know that now. And then your daughter's a physician as well. She was really nice to have like phone a friend when the doctor came in. So really like, again, I know you touched on it that like circumstances really lined up pretty well for you. Like in the moment, like the micro circumstances, like the fact that there wasn't traffic, but the cath lab was open till 9 and like at 8:43 or something, they got the call. So they were still there. I talked to them in the elevator after. It was like, no problem. Actually, we weren't off for the day yet, but it was 15 minutes later or whatever. The ambulance specifically, like all of those things going through. But then the macro for you, as far as like, you have a really supportive and helpful family and something like that that can make even this a little bit smoother. So it was just adorable. It's nice, you kind of see who a person really is. I think when they're like kind of in a situation like that, you're a damn good guy, Doc, and it's really nice to know you. So tell us anything else you want since that moment moving forward, and then we'll get into our 5 questions.
Yeah. So I think that, again, maybe just a couple of other things to highlight about the experience itself. But then it was, again, this period of time of being cared for and it's again, I don't think we should also look past the team there at Mount Sinai Beth Israel. So Dr. Hugo Rosero, who is my cardiologist, and they did a fabulous job, but all of the nursing staff, the support staff that made the stay and the very beneficial for me, as well as the cath lab team. So it's so easy to look past the expertise and skill that all these people have, and just as you talked about, the presence of them being there and availability. So being used to it from the provider side, sometimes it's kind of inconvenient, but you obviously you can't control when emergencies are going to happen, and so appreciate all the care that was provided in that regard. But the rest of the hospital stay, without getting into the real long timeline, really then went, I think I would say, pretty uneventfully overall. It was a matter of getting started on sort of standard medical therapy for almost anybody who's had a heart attack, and just trying to get back on track. And in the way that talked about how I'd had just finished almost a 3-hour workout. The following day, I could barely get up to go to the bathroom without feeling like I was exhausted. So in the way that any of us can really be set back suddenly by health events, that was very humbling, to be honest with you. But I think also speaks to the fact that, getting more into the discipline of what you do, injuries, even to people that are really fit, you have to look at from the long timeline. And that's been very much my approach since then, is not to say, let me next week be back to where I was. It's, very much you've got to listen to your body, take the longer timeline, and then, kind of follow the directions of people that are around you with expertise. And so, again, I think that the role that you serve, and having had a couple of physical injuries myself in the past, I think that the rehabbing, if I can use that term, it's so critical if you've got the right person there to be guiding, leading, and giving direction to what should be done.
Yeah, of all the times that you're going to want to slow cook something, it's right now. Just take your time and be patient with it. And it is nice. I mean, heart rate monitors are not expensive, and they do give very useful information, because almost all of the science in the cardiopulmonary world is based off of heart rates. And you can do talk tests, you can do Berg rate of perceived exertion. Why not just go out and buy the chest strap and just kind of use it as data? I'm not saying get obsessed with it, but we are luckily at a technological point where you don't have to be in a proper rehab facility to have that heart rate monitor. Just go out, splurge whenever. So that's pretty nice. Now, from that day, you've been slow cooking your fitness back up. Is there anything that you learned along the process, kind of from that day till today, that's made you feel any differently about what could have happened that day, or things you could have done differently to lead up to it? And again, then we'll get into our 5 questions and kind of educate some people.
Yeah. So, maybe just to articulate, to start with what I have been doing. So for the first 6 weeks after the heart attack, it, literally was just kind of walking was the extent of exertion that I undertook. And, it wasn't that I was completely limited at that point, but that was, the kind of the directions that I had, and combined with all I felt comfortable doing, until I really circled back and had a chance to talk to my cardiologist about, well, what is feasible. And the next recommendation then, starting at that 6-week point, was to really just do, and you sort of touched on it earlier, but they kind of used the ability to still carry on a conversation ought to generate the level of pace that you go. And so, with circumstances being as they are, and not really having access to a gym, much as I guess there's not many people, unless you have it in your basement, that do these days. So I really haven't been doing anything in the way of weight training, but I've been able to start running again. And so to, again, backtrack a little bit, and we'll kind of get into this probably with the questions, but prior to this event, I had been contemplating running a marathon, had been getting up to running around 30 miles a week, and was really feeling about as fit as I had endurance-wise for probably the better part of a decade anyway. And, what I'm doing now is I've done some runs up to probably about 6 miles, maybe is the longest I've done since the heart attack. And I think what's really different, though, is just the pace. I, used to think of myself as kind of a 10-minute mile pace, and now it's much more to sort of keep that ability to converse. I'm probably much more at the 13 or 14 minute pace, but I think the upshot is, as much as many of us kind of obsess over numbers or metrics, it's so much more, I think, just getting out, and the physical benefits, obviously, of exerting are evident, but probably not dissimilar to a lot of people in these times of COVID. Just being outside is great, doing something, and then having some the sort of mental benefits, if I could say, of exercising has also been a real plus as well, to being able to get back to it. And so that's sort of where I am right now, and have another assessment that I'll probably be doing in about 4 to 6 weeks again, including another echocardiogram to kind of assess what can be done medication-wise to maybe taper a little bit of the regimen I'm on.
Perfect. That leads us into our first question. Are CPR and AED training valuable? The ultimate softball.
Yeah, there it is, lobbed underhanded right over the plate, right? So, yeah, so I think I would say the answer is absolutely. And you really can get with the basic CPR training class. I did one in New York probably about a year ago, and I think it was maybe an hour and a half total, and maybe not even that long. So it doesn't take very long. It's not very hard, and but conversely, it can make a world of difference if you encounter someone who is, either had a cardiac event or, that's what the possible concern is. It really, just a little bit of familiarity with it can go a long way. So, we talk, now in this time of COVID about the sort of the societal responsibility for everybody else's well-being, and this is a way you can extend that. If you have expertise or familiarity with those, it can make such a difference.
Yeah, and I would encourage everyone to go do in person at least the first time that you do it. Then there are some online ones. If you don't necessarily need to feel the amount of pressure and use the dummy, I mean, you can do it in the amount of time that it takes you to watch 2 episodes of Queer Eye. You could be done with your CPR AED training and then go straight back to the Queer Eye and continue to watch that for sure. So it's not too bad. And then a lot of them kind of couple with bloodborne pathogens and things like that. They're not things that, like, I think people think because I'm a physical therapist that I encounter this stuff every day. I don't necessarily encounter this stuff every day. So just as important kind of for me to do it as it is for you to do it. The other two things, and this is just kind of worth mentioning, but like you were one person that kind of like, I was there in a moment where it kind of could have gone either way. Obviously it went great and all is well. The two other times, and I just feel like to take the platform and use it for a second. One is we caught a DVT on one of our patients. So he was a coder that was launching a new website and was sitting so much. The standard thing is like, were you on an airplane? Were you on an airplane? Were you on a transatlantic flight, like a long flight, whatever? It's not always the case. Sometimes it's a coder who really needs to get this website out and done and was sitting in a chair for 11 hours a day. He ended up getting a blood clot in his calf. He came in for a calf massage to make it feel better to the muscle strain. And relatively immediately, shout out to Carl, him and I identified we were not dealing with a muscle strain. We got him off to the city MD, off to the ultrasound. He went straight to the ER. I think when he Googled what a DVT was, then he wrote a very kind email and then subsequently bought us drinks. But yeah, that was like one time where it kind of could have gone either way. And again, right now it's summer. This feels like it's worth mentioning. But the other time when I've actually been there when it could have gone either way was when I was surfing down in Costa Rica and someone wasn't being cautious with the rip currents. And she ended up being okay. Her husband ended up being okay. But it was one of the worst experiences that I've been through. If you see any signs for rip currents, or if you don't, just ask the locals, or just maybe just don't go in the water if you're not familiar with the beach, because that can be really problematic. So, side note on that, bring us back to our second question. Is speed of intervention a factor for survival?
So the answer is yes. So it's it influences not only the survival, but also the extent of how big a heart attack or myocardial infarction, using the medical term, how big it might be. And it's all relative, but certainly the goal, and it's the same, we're kind of leaving it out, but for patients that have had a stroke or a TIA, a transient ischemic attack, it's, very much analogous where, the time is of the essence, and really, if you can get intervention accomplished in under an hour, that's phenomenal, which it was pretty close to that in my case. But, that often means all the stars have to align almost. But 2 hours is really kind of the point of inflection where after that, many times the damage, that doesn't mean that things can't improve on their own or that you can't have a good outcome, but that the longer time leads to more damage or the higher possibility that a patient or an individual might not survive. So that's kind of the time frame. And so that obviously there can be a whole lot of barriers that can come up to making that not be possible. The patient being stubborn or denying the symptoms, somebody else not recognizing that could be the case. So I think there, more for the non-medically indoctrinated, if there's any doubt, just do as you did and call 911, and somebody will be there sometime soon that can help assess that, rather than, scratching your head and saying, I wonder if it's going to be bothering somebody calling 911. I would just say, do it. If it wasn't necessary, no harm done, basically, in so many regards.
That sounds, now just for anyone who's listening, and I feel like this is just can you give us the Cliff Notes version of what a heart attack is? You said myocardial infarction, obviously, cardiac arrest. If you want to touch on that, it's totally up to you. But can you just help people who maybe aren't familiar with it? And most people who aren't familiar with it are lucky, and unfortunately that luck's going to change someday, and it's worth you knowing, just on a very broad sense, what's going on behind the scenes. Can you tell us a little bit about that?
Yeah, so in essence, a heart attack is it more, almost always, I guess I would say, is going to be related to progressive narrowing or atherosclerosis of one of the coronary arteries, so the blood vessels that supply the heart muscle itself. And so there's probably kind of, two variants of it, I might say, but the main ones being that there's been a progressive narrowing. And so one day it's gotten to kind of a critical point where now the blood supply is inadequate, and that may be in response to some stress, working out in the gym or shoveling snow or something like that, where the heart's trying to get enough oxygen to do the job that you've imposed on it. And it's gotten to a critical point where there's just not enough there to do that. So that is a type. And then the type that, everyone sort of presumes, and again, this is based on what what's called the angiogram, or the study that was done in the cath lab to look at my coronary arteries specifically, but that you can also get just an area where there's an atherosclerotic plaque. So it's almost like a calcification is maybe the best way I could describe it, that was on one wall of the artery, and it was by no means occluding or blocking any time previously. And then for some reason, all of a sudden, you get some bleeding into the wall underneath that, and it lifts that plaque up to where it then closes the artery off very acutely. And since we've talked about COVID, that's been kind of the concern with COVID when people have talked about these events, these kind of vascular events, is that it's presumably these plaques, and whether that's causing strokes because of the arteries going up to the brain, or in the heart itself, that's presumably more what is triggered with this bigger inflammatory process. So.
Okay, fair. All right. Thank you for that information. That was honestly, you just told me a lot of things that I did not recall from physical therapy school. I appreciate the free information. So, what should you do before starting an exercise regimen?
Yeah, so there, I think, and at the risk of this sounding like a paid political announcement for the American Medical Association, but I think that again, everybody's at a different point, and if you're 18 years of age, you probably don't have to be as worried as if you're somebody at my age at 66. But I think it very much ought to be if you're really embarking on something that's either completely new or at a level, and I kind of talked about as an example saying I think I'm my New Year's resolution, I'm going to run a marathon this year. Before you kind of take that on, it probably makes sense to get in and see your healthcare provider, whoever that may be, physician, physician's assistant, nurse practitioner, but somebody who can then do a general assessment to kind of screen you for what sorts of risk factors you might have, what symptoms you might have that you might not recognize or appreciate that could be cardiac related, and kind of work out an appropriate plan then for assessing all that. So things like family history, make a big difference. And so if you say 6 of my relatives died of heart attacks before they were 50, you really have to have a titer of concern that's much higher than if no one in the family that you're aware of has ever had problems in that regard. People who are former smokers, and again, a great thing to stop smoking if for a whole variety of reasons, but in particular related to heart disease, somebody who may have smoked for 10 or 15 years when they were between 20 and 40, and then all of a sudden at age 50 has hadn't smoked in 10 years, but damage may have been done in those years that cumulatively then can lead to increased risk. Then clearly symptoms, if you get shorter breath, if you have chest pain, and I think the other thing to underscore here is that symptoms of a heart attack can be extremely variable. The adage, when I was a medical student, was any pain from the chin to the knees could be a heart attack almost. And so it can be abdominal, it can be chest, it can be in the shoulder, towards the back, going up the neck. All those are possibilities. And many times people attribute it to something else. It's indigestion, heard B say it's heartburn, when I had my event. But, there are a lot of other common things that can cause pains that are confusing or potentially confusing in that regard. So I think it's always good to be thinking about that. And then, maybe, one of the things to be aware of, and this is both from a patient standpoint and a provider standpoint, but we have kind of this image of the standard patient, who's prone to a heart attack, who's, an overweight smoker, but sort of thrown in there might also be males, and, women also are very, prone to heart disease, often not appreciated. And so, again, I think it's just kind of a good thing for people who are advising or working with individuals who are thinking about gearing up their training to, not sort of think, well, women are immune from heart disease. In fact, they're not, studies have shown that their complaints or symptoms often aren't taken seriously when they are having cardiac disease. So sort of bearing that in mind from the standpoint of what needs to be considered.
Yeah, and I know you're not a cardiologist, but maybe you would have some input on this. How would you coach your GP to give you the best version of themselves when they're trying to clear you for an exercise regimen? I'm not putting down physicians at all, but I think sometimes there can be very different experiences where a physician could maybe not even, or maybe like listen to your carotid pulse through there to all the way through, maybe looking at your C-reactive protein levels. I know that there's a lot of different things, your cholesterol, triglycerides. Just give us your impression, if you want, how you might coach your GP or cardiologist to get a thorough look at what a pre-screen would look like for an exercise regimen.
Yeah, so I think you've highlighted some of these things. So really, a basic physical exam goes a long way, and it's not that you're going to necessarily pick up evidence of coronary artery disease by listening to the heart, as an example. You did talk about the carotid arteries and listening for abnormal sounds there, or what are called bruits, that can be indicative of narrowing. But I think that family history is a very important one to be aware of. And then, the broad sorts of screening things, the cholesterol you talked about, and HDL, LDL levels, specifically looking at that. There are, I think it's probably not a bad idea at a certain age, and I can't give you an exact recommendation, but getting an EKG done just so you've got a baseline, because there can be occult changes that can be picked up there. And then I think that if there's any question, either as somebody has started an exercise regimen, or even if they have, apprehension, and, to some degree, this is pertinent to my own scenario now, where, getting a stress test or a stress echocardiogram done to actually look at the dynamic function of the heart as you maybe on a treadmill or maybe doing some other activity, as a, even better way to try to look for, evidence of that. I would kind of flip that around, and just because they're, they've had a lot of popularity, I think I'll sort of put it in the last decade range, but, getting a CT scan to look at your coronary arteries, it might pick up evidence of plaque or calcification in the arteries, but it's really not terribly helpful by itself as a parameter. And I don't think most cardiologists in particular would say there's value in that. And then kind of the very, last stages are other tests that, can be done. But, the angiography is really the gold standard. So not many individuals is that going to be necessary to be doing. But, if it's kind of unclear, somebody's got some symptoms that are suggestive, should that be done? It kind of becomes the last, the best, but most invasive screening test. So angiography or cardiac catheterization, same thing, where you actually then can look at the arteries in real time and see if there's any areas where there are narrowing or blockages that could be problematic.
Cool. Thank you for the very thorough answer. I wasn't sure if that was going to be 5 words or 500, and I really appreciate what you gave me. Thanks. So you touched a little bit on family history, but does lifestyle play a role in heart attacks?
So I think the answer would be to say, absolutely, it makes a difference. And, touched on smoking already. And in the medical world, that tends to be sort of rated based on a parameter known as pack years. So how many years you've smoked multiplied by the number of packs per day as a way to get that in aggregate. So just as an example, somebody who, when they were 16, smoked 3 cigarettes a day with their friends, in the park, and then quit, after that, shouldn't have to say, well, I'm a former smoker, I might have heart disease. I mean, the odds that that's going to create a significant increased risk is going to be pretty small. But the, other lifestyle things, we just broadly think that being sedentary, meaning not very active, works against you at making you more at risk for heart disease. So there's probably, in the grand scheme of things, it may not be as important, for instance, as smoking or having a high cholesterol, or having, diabetes is another example as a risk factor for vascular disease. But for having a heart attack in particular, those would really accelerate things more significantly. But I think that it goes without saying that the more active you are, and the more doing aerobic activities in particular, the better. And so, without trying to, again, sound like more of an expert than I am, or make too much distinction, but somebody who lifts weights a lot but doesn't ever do anything aerobically, like running or being on a bicycle, or whatever it may be, jumping rope, that probably isn't as beneficial as more prolonged swimming. Another great example of something where it's those sort of total body workouts that really trigger and condition the heart. So it has real benefits, I think, in terms of avoidance of heart disease. But I guess I would say, as sitting here as a case in point, it doesn't mean that you can't be affected, of course, but it's a game of statistics is maybe the way I would say it. So, and diet, another one, steering towards diets that are lower in cholesterol, the so-called Mediterranean diet, seemingly preventative. And once again, it's not if you for 2 weeks had nothing but omelets when you were on the paleo diet or whatever it may have been, that, it's not going to tip you over the edge, but it's much more those kind of long-term life habits, I guess I would say, that can make a big difference as well. So a lot of, fairly simple things that can really make a difference. And then to some degree, there, are many individuals who have something they can't control, and that's where more intensive medical intervention is necessary.
Yeah, and I'm glad you served me up kind of nice as far as exercise, and then I'll touch kind of through. I think this is a really easy thing right now. Anyone can do it. Take your resting heart rate. If it's not below 60, you have some room for improvement in your cardiopulmonary or aerobic exercise system. When we're talking about that, there's really kind of 2 things that you want to do. When someone comes to me, the first thing that I want to do is just see where the resting heart rate is at, whether they're just trying to live their life or we're talking about performance, because that fueling source for high performance, the thing that refuels it is the aerobic energy system. So in general, to kind of break it down so everyone kind of understands what we're talking about, the reason why 60 is a really good number to have a low resting heart rate is it means that heart can actually pump out a good amount of blood, meaning that what's called the stroke volume, or how much each time it can push through, is up. And the way that it gets up is 2 different ways. The chilling and around way, which is just right now, is that it actually does stretch a little bit. You can get what's called eccentric hypertrophy of your left ventricle. That sounds super fancy and like a really, I know, big words. And all it means is that the last portion of the heart before it goes out into the body gets out a little bit bigger. It just stretches out a little bit. And that's really nice because it lets it push more blood out with every single beat, and that's great. The other thing would be what's called concentric hypertrophy, which means that it's stronger and can force that blood out a little bit faster. Now we're talking about someone who's exercising a little bit more. Having a good balance between eccentric and concentric hypertrophy of that heart makes the heart, when you're not exercising, have to work way less. And that's really nice. I'm not saying that you want to work the heart, obviously, in certain areas. We tend to abide by the World Health Organization that you should be doing 22 to 44 minutes every day of moderate to vigorous exercise. Moderate being termed as you could talk, but you couldn't sing, and vigorous meaning you can say a few words, but you can't get out more than a cluster of them. Those are nice guidelines, and I think people lose this. And if you listen to all of our webcasts, you probably are like, shut up, Steve. We've heard you say this 100 times, but just simply walking around doesn't tick those boxes. If you can sing while you're doing it, it doesn't give you 1 minute of moderate exercise. So that's just something to look at. So as far as that is, then the other thing as far as lifestyle, and I think you spoke well, in general, we walk people through an elimination diet process to find what their body really likes, to try and get their inflammation as low as possible. There is, and correct me if I'm wrong, but an inflammatory component. And I know that you're okay with this kind of because you talked about the COVID inflammatory component of it, but there is an inflammatory quotient to atherosclerosis, or that narrowing of the arteries. So finding out what your body is upset about and what it may be giving you an increased immune response to something as simple as having improper balance between the bacteria in your small intestine and your body knowing that there's more bad intestine than it likes. So sending an inflammatory response there can end up affecting your body in other ways. We tend to side with the USC Longevity Center that is kind of a primarily vegan plus pescatarian, if you will, diet. If you want to check that out, feel free to look. It's not too different from the Blue Zone diet. Some people claim that the Blue Zone has a little bit bias. I followed Walter Longo's work for a while. He's the USC Longevity Center head. I followed his work since I was actually in college because my physiology professor followed his work. I don't get a sense of bias on that guy, but again, do your homework, check it out and see whatever you think. But yeah, it is nice to like almost find out what your body really likes, get your inflammatory quotient as low as possible, and then we can start talking about diet. So that's it. And I really like that. To lead us in, you touched on this saying from like anywhere from, I feel like the ears to the knees of what a possible heart attack symptoms might look like. But just tell us if there's anything else that like people could look for. I know men and women can sometimes present differently. Even like women can sometimes take an antacid and that can help with symptoms that are a heart attack. But just talk us through that. Give people a bit of a robust answer to the question of how might I know I'm having a heart attack?
Yeah, and so, and again, as having started off by detailing to some degree my own symptoms and sort of lack of awareness early on, but it really can be variable. So, I think things to highlight in that regard is that clearly avert chest pain, kind of below the sternum or the breastbone, is going to be one of the most classic, but pressure and just sort of a heavy feeling. So it may not be avert pain, but this description of what feels like something sitting on my chest. Another example of that, then, sort of shortness of breath or feeling lightheaded as, evidence of the latter one, not perfusing the brain, the former being the heart just not pumping out, adequate blood to kind of keep things from backing up into the lungs. So it's really a variety of things, and it can be more abdominally based. It can even be, relatively silent, meaning that there's not much pain at all. And so is there a sort of a classic pattern? And the answer is, when you see patients in an emergency room, to do what's called a rule out MI, or to exclude somebody from having had a heart attack. There's this whole spectrum of symptoms that may allow you to be included in that. And the more risk factors that somebody has, the more attentive you ought to be. So, that everything from age, things we talked about, presence of diabetes, smoking history, high cholesterol, family history, they're all kind of an additive to be thinking about that should make you more suspicious. So it's, talking about that, the emergency room setting, it's a pretty wide group of patients that will get included in that rule out MI category. And this is sort of the lesson you learn is probably far better to check the blood test to look for it if it's kind of crossed your mind to do an EKG than it is to, ignore it or look past it. Just two other things I was going to comment on real quickly. One of them was when you talked about inflammation, and I must say, one of the things that a lot of people look past is oral health. So getting in to see a dentist, we tend to say, well, fitness is all about my body. But good dental care, which again, a lot of us struggle to find a good dentist where we are, but is the mouth can be very much a source of that. So making sure that that's not something that that we look past in that bigger scheme. And now I've forgotten what the second one was, so that's my cue to turn it back to you, I think, Steve.
Okay, and I'll give a shout out to my cousin, Dr. Christopher Perry in San Antonio, a phenomenal dentist, and my uncle, a phenomenal dentist down in the Red Bank area, Dr. Joseph Perry. So San Antonio, Christopher Perry, Red Bank, Joseph Perry. Look no further than them for your dental needs. Let's take it back. So give me a little, just tell us, and we're going to go into the Q&A in a moment, but is there any sort of kind of conclusion that you want everyone to kind of draw up? You've very cleared a ton of different questions, I would say, that a lot of people would have in their mind, but is there anything that you thought of while I was talking that you want to just kind of touch on again, or you think we can go straight into the Q&A?
I was just going to say, I'm not sure that there's a whole lot that it comes to mind, to be honest with you, that I think we've really done a pretty thorough job of, dissecting through all of this, to be honest with you. So nothing that comes to mind, but I, won't hesitate to interject as we're, getting into some questions that, something else that may be lingering from previously. Beautiful.
It's your world. Anyone who's on the webcast right now, ask us any questions. I'm going to just continue to talk a little bit about kind of our shout outs again. Hopefully we're going to be able to get an EMT, some of the paramedics here. Cannot say enough nice things about them. And again, like you said, almost at the hospital, they made it look so easy that I almost forget them in all of this. They couldn't have been better. And it was so nice. That also, shout out, way to go, Gotham Gym, to have the appropriate stuff on hand. And that is going to take you, I'm going to give you the one question that came through. It's not a question, actually, it's a statement. It is from Big Mike Castle. He loves you and he misses you. Your wife is lovely. She perhaps said the nicest things that have ever been said. And Shelly, thanks for your input as well. So with that, we will say thanks. Doc, I know you're still affiliated with Doctors Without Borders. Is there any place that people can find you, or is there any place that you want to make people aware of that they can donate or anything like that? Just give us that last little thing and then we're going to get out of here.
Okay. Well, yes, I would just say, having, spent a considerable amount of time over the last decade working with Doctors Without Borders, and, I just have a world of admiration for what the organization accomplishes, and the the people within it, and how, in so many ways it's an empowering organization for, for people who are, very capable of getting on their feet, but their circumstances may not allow it based on where they are, or, other challenges they face, conflict, natural disasters, and so forth. So, yeah, a great group. Another group that I'm still involved with, something called the DNDI, which is Drugs for Neglected Diseases Initiative, and once again tying in very much with this time of COVID, but advocating for fair pricing of pharmaceuticals, which something that so many of us run into. But also a whole spectrum of diseases that don't get enough attention. So either of those are great. I could, put on, I guess, just post my email on the chat space rather than trying to, but it's pretty easy. I guess as I'm saying that, I realize it's, my first name and last name, 159@gmail.com. So all small letters. Be happy to kind of field questions or comments as far as that goes. So, and again, I just to kind of start, or maybe wrap up where we finished. Again, I'm just very appreciative of what you did personally in all of this, so that people out there listening probably already appreciate what a great guy you are. But this particular event, it's at the times of crisis that true character comes through. So thanks once again for all that you did, and same thing to people in the fire department of New York, healthcare system at Mount Sinai, who were just so invaluable in allowing me to to have the outcome that I did. So thanks so much.
Yeah, you are welcome so much, Doc. It was pretty easy. I feel like I genuinely try and go the extra mile for everyone that I come in contact with. But as me and Leola were talking, it's like there's certain people that you just like, not on my watch. And you earned every bit of the emotion that's behind that. That's all that we have for today. I want to thank everyone. Doctors Without Borders, way to go. Don't forget about medicalmissionecuador.org. That's our foundation. Thanks everyone for coming by, and I hope everyone has a beautiful rest of their day and a happy and healthy rest of your days. We'll talk to you later. Thanks, Doc, for being on. See ya.
Yeah. All right. Thank you.